I'm Sufal.
I'm Marvin,
And
welcome to
Tell me about. Hosted by Sufal and Marvin. Hey guys, I'm Sufal.
I'm Marvin.
And welcome to TMA. Today we actually have a really special episode for everyone. It's been a while since we've had like a pure research episode, but pretty much we're going to be talking about kidney stones, their formation, and how to treat them.
Yeah, so I guess we should explain why we're doing kidney stones.
It's kind of a convoluted explanation.
Okay, but long story short, Sufal and I were in this biology class at McMaster, and we had to do some presentation on, I don't know, we had kidney stones or blood loss.
Yeah, it was like extreme blood loss or something.
And we just thought kidney stones was like way easier to do.
Yeah, it was also way more fun.
Yeah, way more fun. Hopefully it's entertaining.
Yeah.
And actually, no. So, what were the odds again? Like of us being partnered? We didn't pick each other, by the way.
No. Okay, first of all, I think we weren't even in the same lab section originally, but COVID closed down labs, so we had online labs. Mm-hmm. That made us get in the same tutorial or same lab section, and then there's like a 0.2%, less than that, for us to end up in the same seminar presentation group.
I mean, okay, we're not math students, but like, what if there's 24 students and like you had to pair two of them randomly? Yeah, what are those odds, pretty much? But it's low. It's low.
Yeah, someone tell us that later on.
But yeah, okay, so we're doing kidney stones today. Well, I mean, some people have to listen to this, our seminar people.
Yeah.
But for those of you listeners who do not have to endure the next 20 minutes, I guess you can skip around. But if those of you in our class, I'm sorry. We'll try to make this, entertaining, but I don't know if it will be.
Yeah, I think we'll do a great job. Also, big shout out to Emily Garrett, our TA. She honestly jumped hurdles. I assume jumped hurdles. She can tell us later. But pretty much, we asked her like, "Yo, like, do you think we can do a podcast?" We learned about our mutual admiration for SYSK.
SYSK.
Yep, great podcast. Kind of what we modeled ours after.
But we're not copying.
We're not copying. Yeah, we're not plagiarizing. So also, big point that you guys should be aware of, we do have visuals for this podcast specifically. Now during our presentation we'll be playing a YouTube video that you guys can also access. It's a link in the description. It has a visual synced up with what we're talking about, but if you just want to scroll through the slides real quick, we also have a link to some Google slides. So now that we've kind of covered why the hell we're doing this podcast, let's talk about what exactly a kidney is. Marvin, do you know what a kidney is?
It looks like a bean.
Great point. I'm going to touch on beans later, but kidneys are an organ that are touched in, excuse me.
Okay.
Kidneys are an organ found in vertebrates, and us humans were vertebrates. Some other
kidneys,
vertebrates
right?
I can think about off the top of my head are like fish. Yeah,
Okay, so they have kidneys.
Fish or cats.
Oh, my cat has kidneys then.
Yeah, exactly. So in terms of visual aspect, they look like a bean, like you said. Yeah, they're like a bean, but like larger. Like fist size. Actually, I don't know.
Actually, I googled this. Pretty much, a kidney is the size of your fist. So, if you a clenched fist. That there was emphasize a clenched large fist.
Oh, large, whatever a large fist defines as. Yeah.
But yeah, a kidney bean. Actually, no, kidney bean. A kidney bean. Well, kidney beans look like kidneys.
Yeah.
But maybe we should say kidneys look like beans. Okay, whatever.
Okay, that's actually a great point, but we'll talk about that later after the podcast, okay? But pretty much they're found in these places in our body called retroperitoneal space, the right and left, because we have two of them. And if you want to like feel your body and kind of estimate where it is, imagine you had abs, rock hard abs. So to like the top, you do? Okay, cool, I guess. To the right and left of where abs would technically be. Purpose of kidneys, well, I'm sure everybody in our class knows this, but they're used to filtrate our blood, take waste products out, and put it into our urine. A side fact that's actually pretty relevant is we produce about 0.99 to 2.3 liters of blood a day. Sorry, liters of blood, my apologies. Urine a day. And the pH of urine is usually between 4.8 to 7.2, which will be relevant later on. And kidneys also control the volume and electrolyte concentrations and composition of all bodily fluids, including urine, blood, and whatever else we have in our body.
Yeah.
So now that I've butchered explaining about where exactly kidneys are, I'll let you talk about the functions.
Yeah, so I'll butcher this part. So yeah, there's 4 functions. Honestly, it's a little bit of a rehash, but just to mention it, kidneys are responsible for filtration, reabsorption, secretion, and excretion. I don't have an acronym for this, so you just have to remember, I guess.
FRSE.
No,
that's the first. Yeah.
Okay, but yeah, filtration. We learned that kidneys apparently they filter 108 liters of volume a day. Through hydrostatic pressure, and it's just to get rid of waste products, right?
Yeah.
So waste products, but we do want to keep some stuff, so that's why we have function of reabsorption, and you do need to keep some sodium. Some water is important too, and glucose. So it's kind of like a balance between reabsorption and filtration, which I think we're going to mention a little bit more.
Yeah, we will.
Right, and then secretion. This one we're not going to touch on as much today, but apparently, kidneys are responsible for hormone release. I think the one we covered in class was actually renin. But there's a whole bunch of other ones that are also involved.
Yeah.
And then lastly, excretion, because eventually, kidneys, you gotta get rid of stuff,
They
right?
gotta go somewhere.
They gotta go somewhere. So you gotta go from nephrons to collecting duct, to eventually to your ureter, to your bladder, and all this stuff eventually in the toilet.
Actually, now that we've talked about the four functions, tell me more about the bean and
bean?
what's in the bean.
Okay, so the bean, aka the kidney, has an outer part and an inner part. We jokingly say it's an outer bean and inner bean, but the scientific names would be outer renal cortex and inner renal medulla.
Yeah.
So, and the kidney it's made of a bunch of lobes, and each of these lobes has what's in it called, it's made of like a renal pyramid part, and also a renal cortex surrounds that medulla.
Yeah.
So the pointy ends of the pyramids are called papillae. I didn't name this, but that's what they are.
Yep.
And they point towards the center of the kidney and empty into what's called a minor calyx, which is like I guess it's a little space. And then enters a bigger space called a major calyx.
Mm-hmm.
Once again, I didn't name any of these. And eventually it gets to an even bigger space called the renal pelvis. If you're not sure, once again, we have a diagram for this or on a slide, so definitely check that out.
Yeah, definitely. So now that we've talked about the renal pyramid, the cool part, let's talk about nephrons. So nephrons are this thing that I'm sure even people who don't really care about science might have heard
of it, yeah.
Yeah, exactly. Oh, you don't care about science?
Oh, I care about science and I heard of it.
Okay, sure. So pretty much they're this urine-producing structure. They're found throughout the cortex and medulla, the outer bean and the inner bean we mentioned earlier. Pretty much inside the cortex we have a renal corpuscle. The corpuscle essentially has renal tubules that lead to the medullary pyramid. The pyramid that we mentioned again earlier. The renal tubules all collect and drain into collecting ducts. Filtration and reabsorption, pretty much they have a balance, and this balance is super important regarding not forming kidney stones and just having like a healthy body in general.
Yeah, like you don't want an imbalance because it's pretty much the imbalance between these two processes that cause you to have a kidney stone.
Yeah, exactly. Yeah. So nephrons have several parts. We're not going to dig too much into that. You could probably take a course on kidneys on its own. But a few of the parts that are important are Bowman's capsule, which reabsorbs filtrate but unevenly. And this is like a section of the nephron. But this uneven absorption is actually really important because when water is depleted from this section, the uneven reabsorption causes solutes, whatever it may be, like minerals, salts, glucose, all these things we mentioned earlier, to be concentrated in certain areas and supersaturate. This supersaturation of minerals, well, let me simplify it even more. Rocks are made of minerals. Kidney stones are rocks. Therefore, kidney stones are minerals, which come from supersaturation.
What a great argument. Yes, great. Yeah. But we should talk about kidney stones in particular, since our focus today isn't on the kidney. And I guess to start off, some background. Apparently, 12% of the world population at some point is going to have a kidney stone.
Okay, 12% is actually a lot.
Yeah, it's a lot.
I kind of forgot that stat, but that's a lot of people. Actually, a great point I wanted to mention is there's other names to having kidney stones or the disease of having kidney stones.
Okay.
And if you have kidney stones, you're in luck because you can make it sound scarier than it is. Okay, so I'm gonna say the two names and you rate them. Okay, out of 10. Okay, nephrolithiasis.
7 out of 10, I guess.
Okay, that's pretty good. That's higher than expected. Okay, urolithiasis.
No, 5.
Yeah, urolithiasis, I don't know why, it reminded me of some type of string. Anyways, yeah, so lithiasis, let's just break down those words real quick. Lithiasis basically means a formation of stone or calculi, and it happens in two places: the nephro, which is a descriptive word for kidney, or uro, which is urine.
Pretty much the reason they sound scary, at least to me, is because they have the iasis in it.
Oh, yeah.
Right, and we learned, I guess in MedTerm, if you guys have taken the course, that iasis pretty much means some sort of condition. So anything with an iasis is not good.
Yeah.
But yeah, I guess we should talk about the specific mechanism behind these, stones or calculi?
Yeah, so calculi, not calculus, the math, which I'm sure all of you have great experience in, refers to calcification of something, aka the hardening or concreting of something.
If you're learning about kidney stones, there's one word you're going to come across a lot, which is supersaturation. We don't know why it's called supersaturation. We didn't name this.
Yeah.
We're thinking, what name did you think of, Sufal?
Okay, yeah. So I was I thought of this whole process. I'm like, yo, there must be extra saturation, fine saturation, or crazy saturation. They probably went through. There's some scientists that went through a bunch of names, right. And one of them was probably yo, supersaturation. Yeah, alliteration on point.
Yeah. But yeah, I guess supersaturation, and it's pretty much where you have all these caliogenic substances, aka these crystal formers, in high concentration, and that's what really it's saturated with.
Yeah.
But yeah, these caliogenic substances form. Well, it sounds like a video game sort of. They form these seed crystals. Of some sort.
We brought this up earlier while we were researching this topic. Seed crystal, 100%. Some rare item in some game. I just know it, okay? I'm sure some of you guys are thinking about it already. But these seed crystals, they form through this thing called nucleation, heterogeneous nucleation specifically, where the seed crystal is found in the papilla. We mentioned it earlier. It's the top of the pyramid. Essentially, it aggregates and grows into a bigger mass, aka the stone. And since we need to break it down a bit more, because nucleation isn't a term, I throw.
Yeah, I have no idea.
I don't throw around casually. Nucleation is defined as a random formation of a mass, usually through a distinct thermodynamic process or through a change in phase, and it has two flavors, one of them being heterogeneous and the other one being homogeneous. So heterogeneous is when a phase transformation happens, and from liquid to solid, or like gas to plasma, whatever it may be. And homogeneous is when it's spontaneous and there's no other factors really helping out the nucleation.
Okay.
Now that we've covered that, let's talk about Randall's plaque. Okay.
Who?
Not Randall Park. I know you heard Randall Park. Right? Great actor. I love him. Fresh off the boat. Great series. But Randall's plaque, I'm assuming is also named after some guy named Randall.
Another Randall.
Yeah. It's like basically the start of kidney stone formation. So Randall's plaque is caused by when there's some interstitial tissue damage caused by oxidative stress. So this oxidative stress causes damage to the urothelial covering the renal papilla to calcify. So pretty much what that means is, just to simplify it, is there's this urothelial covering is like a type of membrane that's on the renal papilla, the tip of the pyramid, and essentially there's damage there, so it starts calcifying. Why does it calcify? Well, the nephron, that part of the nephron is exposed directly to urine. There's no longer a membrane like as a barrier, and that exposure causes, a plaque to build up. The minerals are attaching to it and building up. In most kidney stones, Randall plaque is the attachment point where calcium oxalate stones, which we'll talk more about later, forms. And another type of crystal is a calcium phosphate crystal. The calcium phosphate crystals actually don't form with Randall plaque. They form further down the whole kidney chain, further down the nephron tubule, and it depends more on pH for its formation, and also needs high calcium concentrations to cause more nucleation. And important point to actually mention is the fact that calcium phosphate crystals do dissolve, but the second calcium oxalate bind to it, even if the calcium phosphate does dissolve further along the chain, the oxalate still remains. So like the two can bind together, kind of.
Oh, okay, yeah. So you can have a mix of stones, pretty much.
Yeah,
right?
yeah, exactly.
Okay. Oh, but you didn't mention pH,
Yeah.
which is, I guess, pretty important to mention. I guess I can expand on it, but pretty much, related to nucleation, pH is pretty important. And the reason is because, I guess, depending on your pH, you have a risk of forming different kidney stones. So it's not that super acidic is good or super basic is good. Both, this is pretty common knowledge. If you have an imbalance in anything, it's bad. But specifically, if you have a higher pH, then you're more likely to have those calcium phosphate containing stones. But if it's more acidic, then it's more of those uric acid or cysteine ones. And the reason, at least I guess, for the uric acid one is because if you have low pH, it's because there's more uric acid in it, right?
Yeah.
And more uric acid gives the rise to this term called, I might butcher this, hyperuricosuriasia, aka high uric acid levels.
Quick story about this, like learning how to pronounce this. While we were doing the research, we're like, yo, how do we pronounce this? We find this channel, okay? The channel's name is Pronunciation Guide. So we're like, okay, this guy has to be top notch, right? He won't
it was like a 20-second video too, right?
Yeah, so it's not like a minute-long video. We click play. This man butchered it to hell.
Oh my god.
We've talked about my little rant on that channel. One last thing we should actually touch on is hypocyturia. So pretty much...
You got it right.
Yeah, I know, right? But if you took a medical terminology class like Marvin apparently did, I don't know about him taking a class, but it refers to low urinary citrate excretion. Citrate meaning the thing you typically associate.
Isn't it citrate?
Oh, citrate. My bad. I guess I butchered it the second time around. But it's a thing you might associate with oranges. When this condition occurs, it is associated with 2/3 of cases. So when you have this condition, 2 out of 3 times you're getting a kidney stone. And how does citrate reduce it? Well, it reduces the supersaturation of calcium salts by essentially forming a complex with calciums. Therefore, there's not enough calcium to help build the stone.
Okay. Yeah, makes sense.
Yeah. Okay. We touched up on a lot of the minerals earlier, so let's just jump straight to like what types of
Oh, yeah. What everyone's waiting for, pretty much.
Yeah, exactly. Yeah. The meat of our presentation, I guess. But most people think that, you either have kidney stones or you don't. But that idea is kind of wrong. The most common type of kidney stones is based off of calcium oxalate. Ththese make up about 80% of cases where people have kidney stones. And they form from, Randall plaque.
Who else? Randall's plaques.
Randall's plaques, exactly. And the less common ones are made out of calcium phosphate, struvite, uric acid, cysteine, and followed by like a couple of other minerals that aren't as important. We're not going to jump into them. But what is important though is we mentioned it earlier, it can be composed of multiple things. Like your kidney stone won't purely be of calcium phosphate. There's a high chance it'll have other minerals on it.
Actually, another important thing is because we thought initially kidney stones would just be like stones in the kidney.
Yeah.
But apparently it's anywhere from the kidneys to like the urinary bladder. Like
Yeah.
pretty much anywhere from your kidneys and afterwards, right?
Anywhere down that chain.
Right, and pretty much if it is in the kidney, I guess if we have a diagram here. Hopefully,
Yeah.
it would be in the renal calyces, where the urine collection begins, or in the renal pelvis. But otherwise, like usually it's at the renal papillae of those renal calyces, and if it's not there, then it's somewhere else along the the urinary tract, right? If not in the kidney.
Okay, so let me backtrack again. So we have pelvis stones, we have calyx stones, we have ureteral stones, and bladder stones.
And the first two are in the kidneys. The other two are.
Yeah. Okay. So pretty much we have a low chance of a part where we don't form stones. And if you think that's bad, actually I don't know if you know this, Marvin, but have you ever seen an image of those kidneys? Like it's literally like actual kidneys from a surgery that look like rocks.
I have not. What is this?
Okay, so pretty much there's this thing. I learned about it just doing research about this, but there's this thing called a staghorn stone.
Staghorn stone.
Staghorn stone.
Okay.
Yes, the name is very unique. Again, alliteration. They love it. You know?
Okay.
Yeah, but
Scientists,
it's pretty much like a big stone that fills up the renal pelvis and takes up multiple of these calyces.
So not just one calyx. Like
No.
it's oh my god.
Exactly, and apparently they're really hard to deal with. If you're getting a kidney stone, pray for a smaller one, or pray for none, I guess.
Yeah.
Okay, so now that we've talked about those stones and how they're formed, let's jump into treatment. So let me give you a scenario, Marvin. Say I was born in the 1900s. Do I live? Do I die? Kidney stone?
Might be closer to die. Just saying, but because like chemolysis wasn't a thing until like 1920s.
Oh, okay.
Yeah.
Okay. Oh, well, I mean, I guess that sucks. What, like, say I was born 20 or 30 years later.
Okay. Yeah. So chemolysis was developed in the 1920s, and pretty much for like a long time, it's been used as like the primary treatment for kidney stones. I think the most popular one across the period was like ranitidine, but nowadays we're not really using it because we have way more advanced surgical ones.
And I can jump in on that.
Yeah, Sufal, you talk about this part.
Great segue again. Okay, so pretty much there's three ways to do it. First one being shockwave lithotripsy. Long story short, it's pretty much in the name. You shake your kidney, you break apart the stones. It's really painful, so they knock you out. And it's useful to break it down. Usually 2 centimeters or smaller in diameter. Unfortunately, as you know, when you break a rock, it breaks into sharp fragments, causes kidney damage, a little bit of, bloody pee, and whatever else it may be. And if the stones are large, you can't really do anything. On top of that, it doesn't work for patients who are a little bit more on the thicker side, obese,
Thicker side, yep.
because there's just too much dampening material before the shockwave can get to the kidney. The second option is ureteroscopy. I think I pronounced that right, but it's pretty much popular for like proximal ureteral stones. They use an endoscope, they go in, they remove the stone. That's pretty much it. And the last one is percutaneous nephrolithiasis.
Nice.
Yeah, I got it. First try. But pretty much they make a cut in your back, they use a nephroscope again, remove the fragments, and this one is usually used when there's a lot of large kidney stones because the other two are less invasive. But that's pretty much it in terms of that.
Okay, wait. As a biopharm student, I do have an obligation to talk about some drugs.
Okay.
Although I'll just keep this quick because it's not really the main focus. Once again, surgery is the main thing. But yeah, if some kidney stones can be passed if they're small enough, just by yourself. But in that case, sometimes it can be sort of uncomfortable. So in that case, you want to use something like an alpha-1 receptor antagonist, like tamsulosin.
Yep.
Might have that wrong, but pretty much it helps the ureter relax, meaning you can pass the stone a bit easier. Other cases, you have these things called thiazides, which are pretty much lower urinary calcium. And then allopurinol is something that is a xanthine oxidase inhibitor. And there's a pathway through this where it ends up in the lower production of uric acid because you're blocking xanthine oxidase.
Okay, well, cool. Oh, we actually didn't mention this, but if you think you have a kidney stone, look for these symptoms: intense cramping, blood urine, and UTIs, urinary tract infections. But say you want to prevent yourself from getting a kidney, there's a few things you can do. First things first, you can change your race.
Yeah, I can do that.
Yeah, you can do that?
Yeah,
Okay,
no problem. We did it last Wednesday.
Jokes aside, pretty much there's a scale. Caucasians are the most likely to get it. Then it's Hispanics, Asians, and then finally Africans. On top of that, there's other factors like if you have hypertension or you drink caffeine.
I don't.
You don't drink caffeine?
So I'm good.
Okay, but I think you have friends that drink a lot of caffeine.
Oh,
You told me
yeah.
some story about some. Anyways, that's not part of it. But genetics are also a big factor. Some men and women in different populations can excrete as low as 50 to 500 milligram of calcium per day. And calcium excretion, like even the amount you excrete, is fully based off of your family lineage. Like it's something that's genetic. Oh, obesity is a big factor as well. So I mean, like I know I got a little bit thick over quarantine, so I should probably start losing some pounds.
Well, I mean, maybe you want to cut back on how much animal protein you're having. I know you had pork chops for lunch, right?
Bro, I had pork chop in the summer. Okay, chill.
Okay, well, anyways, and one last one I guess Sufal didn't mention was, males apparently have an increased risk, like double than that females. So yeah, it sucks to be us, I guess, right?
Yeah, I guess.
But yeah, I guess animal protein, let's explain that one, because that one's something we can do something about, right? So yeah, animal protein apparently has a lot of sulfur in its amino acids, and the oxidation of sulfur generates all these protons, which affects the, urine pH, decreasing it. There's also a lot of purines in animal protein, and these get broken down to uric acid. With more uric acid, that means lower pH, and uric acid is actually less soluble with decreased pH, meaning that it has a higher chance to precipitate, forming those uric acid stones, or even contribute to, I guess, what was the term? Nucleation?
Yeah, nucleation.
Yeah, nucleation of calcium oxalate crystals and calcium oxalate stones.
Okay, cool. Well, I mean, I'm very happy with your attack on my pork chop eating behavior in the summer. But that aside, pretty much the amount of sodium and water you take in is going to affect it, and that's completely something you can control. Just jumping into those mechanisms, just as a last idea, if you drink more water, you're going to increase your urine volume, therefore decreasing concentrations of all these minerals, and that can slow down the stone formation process. And stone formation, actually, you just pretty much don't want supersaturation of all these compounds that form it. On top of that, if you take in a lot more sodium,
Like a lot of pork chops.
yeah, okay, sure.
Yeah.
If you take in a lot of pork chops or sodium, well-seasoned, delicious pork chops, you actually excrete more calcium. Why is that exactly? Well, calcium excretion is due to sodium being reabsorbed less, and calcium thus reabsorbed less in the proximal tubule. The majority of calcium that's reabsorbed by passive paracellular transport through the permeable epithelium of the proximal tubule. That's a lot of jargon, but if you look at the diagram we had earlier, that will probably explain what exactly we're talking about. And of course, sodium reabsorption provides the driving force for calcium reabsorption through all mechanisms I just mentioned. So when your body is trying to get rid of sodium, aka those delicious pork chops, you're also getting rid of calcium.
Okay, so pretty much to summarize, if I want to reduce my chances of kidney stones, I gotta change my race, which I did last Wednesday, like I said.
Yeah.
Diet, sex, and yeah, pretty much my entire life.
Yeah,
Yeah.
same for me. Cool.
Okay, well,
Alright.
I think we covered everything we need to, but if you guys want to learn more, there's always more online, there's classes, and of course there's Google.
Yeah.
But yeah, if there's any questions or concerns, feel free to DM us on Instagram at tellmeaboutpodcast, or email us at tellmeaboutofficial@gmail.com. Thank you guys so much for listening.
And I guess we'll talk to you next time, except if you're in our class, because now the question period begins and you can barrage us with your questions. Thank you guys for listening. Peace.
Bye.
Bye.